Entrar where the beef is, con Fasiha, que nos va a hablar de hepatitis C y carcinoma hepatocelular. Esto es causa o consecuencia del tratamiento. Fasiha, su verdadera línea de interés es carcinoma hepatocelular, de tal forma que más allá de sus credenciales que todos reconocemos, es un privilegio escucharle hablar sobre carcinoma hepatocelular. Fasiha, please.
Thank you very much. I hope all of that you said everything was good about me. Okay. All right, so we're shifting gears a little bit. I'll talk about hepatitis C and HCC. And the question that I was asked to address is it a cause? Hepatitis C is a cause for HCC, or is it actually the treatment consequence, especially with the new direct-acting antiviral agents that we have? So let me get a feel from the group. How many feel that hepatitis C in itself is a cause for HCC? I think we're done. I can wrap up quickly. And not a treatment consequence. No, not a treatment consequence. Not a treatment. So, good, excellent. So we are all on the same page. So right now I'll just walk you through the story because the answer, the conclusion, we already know. So hepatitis C, let me just step back a little bit and talk about this condition called cirrhosis. We all know it. I don't have to tell you what it is. It's the final common pathway for all chronic liver diseases, and it is the precursor lesion for liver cancer. Most of the liver cancers, as you know, they occur within patients who already have cirrhosis. And even up until recently, even now, the most common cause for both cirrhosis and liver cancer, these data are from the US, but I've been talking to most of you here, and it's the same story here as well in Mexico. The most common cause has been hepatitis C virus infection. So here, these data are now a little old, but up to 50% of patients in this multi-center study that recruited patients from, I want to say, 8 or 10 different hospitals in the US, when they looked at the underlying reason, about 50% was because of hepatitis C virus infection. There was 15% from hepatitis B virus infection, and about a third, 33%, where it wasn't a viral reason. Some of that could be because of non-alcoholic fatty liver disease, but that is the distribution of risk factors for HCC in the US, and that is way before DAAs even came about. And many studies over many years have looked at the relative risk of liver cancer and in hepatitis C virus infection. I'm showing you some of the data here. So compared to patients or individuals who do not have hepatitis C, the controls, when you look at those who have hepatitis C, the risk is 25-fold higher, 25-fold more higher risk. They're more likely to get HCC compared to those who do not have hepatitis C virus infection. Also, many studies have looked at the actual absolute risk of liver cancer in patients who have hepatitis C virus infection. And if you look at all comers with hepatitis C, it's about 1% at 30 years. But if you just look at that subgroup with cirrhosis, the highest risk group, it is quite prominent. For about studies report from 1 to 7% per year, averages about 3 to 3.5% per year. So it's a pretty high risk group, and we've known about it. These data are not new. Hepatitis C virus infection is the leading cause of liver cancer. And the problem that it is becoming more prominent, and the fact that we've been talking more about it, is that birth cohort effect. So you know the birth cohort. There were people who got infected with hepatitis C virus infection at a different in a given era, before we even knew what that was, and now that group is just getting older. So with that getting older, they have had the infection for a longer time, and of course with that, more and more of them are getting cirrhosis, and more of them are getting HCC. So the reason that it is becoming more prominent right now is just that the hepatitis C cohort has grown older and they have had the infection for longer. So here are some data that we published now several years ago, looking at a large group of individuals with hepatitis C virus infection. They all came to the VA system in the US. Everybody, I'm aware of the VA healthcare system. So it's a semi-closed system. People come and they stay there. Hepatitis C is pretty common. So we followed those people over time, those who had documented hepatitis C virus infection. And you can see from 1996, which is the very right here, of everyone who came to the VA at that time, about 8-9% of them already had cirrhosis, the very top line up higher up. And when you fast forward it to 2006, those are the people who came to the VA in 2006, about 20% of them at that time already had developed cirrhosis in that group of patients with hepatitis C virus infection. And of course, it's not a big surprise that HCC, the bottom line, grew with it. So in 2006, now 10 years ago, out of 100 patients who with hepatitis C virus infection who were coming to the VA, 1 out of them already had liver cancer at that time. So it's a pretty remarkable finding, because it really is very similar to what we are seeing in our clinical practices, and not just the VA, but elsewhere as well. And these data are still the same. So it was 2006, older data. These newer studies looking at information from up to 2013 and 14, and it's the same story. About 60% to 70% of liver cancers that are seen in this large healthcare institution, even now, are hepatitis C virus infection. So yes, we are worried about NAFLD, we're worried about NASH, we've been talking about alcohol all along as well. It's not there, at least not in this system. It still is hepatitis C virus infection. Now, the little wrinkle that came in this story was with the new treatments that have become available. We're using them quite commonly. And everybody here knows this remarkable story of how the treatment evolved over time. For decades, we were using pegylated interferon ribavirin. That's the treatment we had. It was very long. People got sick on it a lot. Less than half responded. But that's all that we had at that time. But then in 2011 onwards, we had the first generation of direct-acting antiviral agents, the telaprevir and the boceprevir. But more recently, in 2014 onwards, we have this remarkable new day of very effective, very safe DAAs that, with treatments as short as 8 weeks, can cure most of the patients. And they're so safe, patients don't even know that they're on it. So it's a very different time that we're living in, and it has really resulted in a lot of patients getting viral cure, or SVR. And we know from studies that SVR is a good thing. So this study is from 2012, and it looked at 500 patients with cirrhosis who received interferon-based treatment. This was older treatment. And they followed the patients over time, compared those who got the SVR and who didn't get the SVR. So the orange line is those patients who did not get the SVR. And all across the board, looking at different outcomes, you will see the orange bars being much higher than the blue bars. SVR helped. It was a good thing. It protected patients against mortality, liver failure, and also against liver cancer. So it's a remarkable difference in the risk of liver cancer in patients who were successfully treated with interferon-based treatment. We replicated and actually extended these data a few years ago using the VA cohort of individuals who were treated with interferon. So this was before the DAs became available. We looked at these 30,000+ patients who had received interferon in the VA, and we also looked at what happened to their liver cancer risk if they did or did not get cured. And again, the similar results, the graphs, the bars are very similar. For patients who had SVR, their risk of liver cancer was extremely low. It was 70% lower compared to patients who received the interferon, got treated, but did not get the SVR. So it resulted in remarkable reduction in the risk of liver cancer with successful treatment. Now the tricky part here is it was all interferon-based treatment. The study that I showed you before, this study, all interferon-based treatment. The issue happened when we had the DAs, and the earlier studies that we all started to see were alarming. There were several studies that came out and they suggested that patients who were getting DAs, they actually were developing new liver cancers faster, and also those liver cancers were more aggressive. So some suggesting that actually the DAs are causing liver cancer, they're hepatocarcinogenic. So there were several studies that came out, a lot of issues sort of happened around that, but there were other studies that were coming out at the same time that indicated that perhaps not, that might not be the case. So the data were very mixed. Most of the studies were very small. They looked at very small groups of people who were treated with DAs and very few patients who got liver cancer. So they were mixed, we couldn't really tell, and it was a big concern. So we answered that question in a large study that actually just came out a few months ago in gastroenterology, where we looked at the VA data again and looked at patients who actually received the new treatments. These are all new oral DAs, and these patients were seen in over 129 different hospitals. So we were able to get all of that information. We looked at their treatment courses, we looked at if they had SVR or didn't, and then we looked at whether they had liver cancer. And we were very careful, so this is a point that I made for the cohort studies that we were talking about earlier, is that the outcome has to be objective. So our outcome was liver cancer, and we confirmed it doing chart reviews and linking it with cancer registry in the VA for every single case, because we wanted to make sure that we're not overcalling or misclassifying patients with liver cancer. And with this, we had 23,000 patients who received the new DAs, and out of them, most of them did not have a liver cancer to begin with. Some people got treatment after liver cancer also. So we started following those 22,500 patients who did not have liver cancer but got the treatment. And this is what they looked like. So the average age of our patients were about 60. So they're older patients. Mixed in terms of the racial mix. 40% at that time already had cirrhosis. It's a big number, and lots of patients had diabetes. Many were also drinking alcohol. So these are not the types of patients that we treated with interferon. They're very different patients. And when we looked at these patients over time, most of them got an SVR, which is consistent with other real-life data that we are seeing. And we did find significant number of liver cancers, not very many, but 183 in the treated group and 88 in the no SVR and 183 in the SVR group. And this is what the results look like. So SVR actually resulted in a reduction in the risk of liver cancer. The risk of liver cancer in the patients who received the treatment, completed it, but didn't get SVR, the risk of liver cancer was significantly higher than those who actually got cured. And this effect actually was prominent and evident in the beginning, but with time, actually, it became more prominent. So in that group of individuals, SVR was still very protective against liver cancer. And we adjusted for all the factors that I was showing you before. making sure that we're not really missing anything major that could in itself result in liver cancer. And even after adjusting those factors, we saw a remarkable difference. So again, the hazard ratio, you can see, is 0.28, remarkable reduction in the risk of liver cancer in patients who were successfully treated. I did put one other information in here. It's not done as part of the study, but as part of our previous study with using interferon. In that group who were treated in the same healthcare system, treated with interferon, got cured with interferon, their annual risk of HCC was 0.33% in our study. And now we're looking at a similar group, but not exactly the same, got cured with the DAAs, got cured, but their risk of HCC was 0.9 annual risk. Big difference between the two. So those are the data that are leading people to believe or say that DAAs are causing cancers because interferon didn't. But the point is, they are different patients. This is what I showed you before. In our previous study, less than 10% of patients had cirrhosis. Here we have 40% of patients have cirrhosis. Very few were drinking alcohol in our previous study because we didn't treat patients who were drinking alcohol with interferon. Here, 60% were drinking alcohol. And those factors independently were associated with the risk of HCC in our analysis, so they are important prognostic factors. And that's what the slide here, it shows. Patients with cirrhosis, the risk of liver cancer was almost 5-fold higher than patients who did not have cirrhosis in this study with DAAs. Alcohol use was also associated with risk of liver cancer in this patient population. And because cirrhosis was such an important factor, we actually split up our patients, the SVR patients, into two groups. One who had cirrhosis and looked at multiple different subgroups within that group, and then those who did not have cirrhosis and looked at multiple different subgroups within that. And there was a clear divide between the two groups. So patients who had cirrhosis, no matter who they were, their age, their race, the diabetes, alcohol, regardless of any of that, their risk of HCC was higher. So cirrhosis was the main factor that was resulting in patients getting a higher risk of HCC. Those who did not have cirrhosis, they fell really nicely on the lower end of the risk spectrum. So their risk was on the lower side, no matter what else they had, except for those patients who had a high FIB4. So as you know, FIB4 is a marker of possibly advanced fibrosis. We probably were missing them because they weren't diagnosed as such, but that group had a higher risk. So again, indicating that these people are different. Lots of them have cirrhosis, and yes, their risk of liver cancer is going to be higher, but treatment in itself does not lead to liver cancer, actually is protective against liver cancer. There was one other observation that I want you to look at, which is the sample size was small, and I didn't highlight it here, but I'm going to walk over and show it to you. So that finding for me was very remarkable. Everyone who had already had cirrhosis, the highest risk for liver cancer in patients with cirrhosis after DA cure was in Hispanics. So this is something worth thinking about, worth studying further, because that group, the risk doesn't fall as much as it does in other people. So it's something to think about. We also looked at, because we had access to the cancer registry, we looked at different cancers that did develop in these patients and looked at their size, their tumor stage, because there was a concern that when these occur, they're these large infiltrative cancers that nobody has ever seen before, but we didn't see any of that in our study. Oh, that's an alarm for me. It was lower stage and the size was also small, so that wasn't really much of a concern. So this is my last slide. This is a recent data that were presented at EASL. And it's another study, which again provides confirmation to what we reported before. This is a Swedish cohort, smaller, about 850 patients with cirrhosis. And they had patients who, in the same study, who were cured with DAs, and those who were cured with interferon. It's a little different study design, and they looked at these two groups, and what they found is if you look at your right-hand side, the little graph, the very first part is the univariate analysis, meaning they're not looking at anything else. They're just comparing DEA SVR, interferon SVR patients, just head-to-head. And there, the risk of liver cancer in the DEAs was higher, almost 2.5 compared to interferon-treated patients. But if you now look at this table on the side, those patients were different. Interferon, going back to the same point, interferon-treated patients were different, and when they adjusted this all, go back to the right side, the multivariable analysis, the effect disappeared. So again, it provides further information, further validity to the conclusion that actually it is not associated with HCC. So I'm going to summarize. Among patients who are treated with DAs, SVR results in a considerable reduction in the risk of HCC. Our work, and others also confirmed it, did not find any evidence to suggest that DAs actually promote liver cancer, either during or after treatment. However, the absolute risk of liver cancer remains high in patients who are treated with the DAs because they just have a higher baseline risk, especially those who have cirrhosis. That is the group that we'll have to continue to monitor. And we have to take into account this factor as we plan our surveillance programs. Patients who already have cirrhosis, they should stay in surveillance till further studies tell us otherwise. So I will end here and take any questions.
Thank you very much.
And what about the population that had been
Estamos grabando incluso, por eso pedimos que hagan sus preguntas desde el micrófono.
Thank you. What about that population that first had carcinoma hepatocellular and then resolved it like surgery or local treatment and then treated with the DES and then had again carcinoma hepatocellular?
Yeah. So in this study, we did not look at it, but we actually have an abstract that we submitted to DDW looking at that question. There are several other studies that also have come out on the same question, and the results are very similar. It's about 30% of patients who had liver cancer were cured, then got treated with DEAs, about 30% get a recurrence. And it depends on how long, and the most important factor is the amount of time between what we thought was liver cancer cure and DEA treatment. So the longer the time, the lower the risk of getting HCC after. So to me, it was probably going to happen anyways. Patients where we had longer time frame, we're more sure they are not going to get recurrence, and that's why we are seeing that association.
What about the autoimmune? You start treatment, and then you realize the patient has a small nodule. You finish the treatment, and then treat the hepatocellular carcinoma, or do you do something else?
So I do what you just said. If the patient have already, so one thing that we've started to do, and again, it hasn't changed our management very much, is that we do a good high-quality scan before we start the treatment. But if we find something small, we go ahead and treat, and then do the liver cancer treatment after that, or concurrent.
Do you do the tomography in every patient, not only the Doppler ultrasound before starting treatment?
Mm-hmm. So our routine for regular surveillance is still ultrasound, at least in our VA clinics. Yeah. But for patients who are coming in, especially the patients who are coming in for the first time that we haven't seen, and there is a concern that they have cirrhosis, then we're trying to do a cross-sectional imaging on those patients before we start treatment.
Okay, thank you.
I would like to ask you, what do you do if the patient has HCC and he has hepatitis C and he wants to be treated and he is eager to be treated? what do you do? What do you wait? Do you treat first the hepatocarcinoma? What do you do?
It depends on where the hepatocellular carcinoma is, how advanced that is. If it's something that is can potentially be cured. We do have a very good liver transplant tumor board and multidisciplinary clinic, so we get that started right away. And the treatment decision for hepatitis C treatment, I've gone back and forth just because the data have been a little mixed, but if they want to be treated, we go ahead and treat them, especially if they're liver transplant candidates. The only place where we haven't treated is if the HCC is really advanced.
Right.
And that also is after discussion with the patient.
Thanks. Is it possible that when a patient has reached the SVR, you look closer in the surveillance after the SVR and then you detect earlier HCCs? I mean, is okay.
It is possible. It's sort of an early detection bias in a way. The data that I am presenting right now, these are patients seen in 120, 130 different hospitals. And frankly, surveillance is horrible. Our surveillance rates, even in the best situation, is 30%, 40%. Most of the time, it's about 20%. So I don't think that explains that, but in our practices, we might see that. Ray had a question.
So, because we're talking about evidence-based medicine, I need to be critical.
Can we do it afterwards?
So, I think this is an observational study, and in trying to, be really firm about the relationship is, it's, we need to be careful. And what I wanted to ask you is when you show the Kaplan-Meier curves, they started diverge at 5 months. So it is way too early for me that if curing hepatitis C is going to affect cancer development, it will take some time. I don't know how long, but 5 months sounds way too short. So I'm sure you thought about that, and I would suspect that there's still element of confounding that non-SVR patients had something that set them up for higher HCC risk, right?
Yeah, no, it is possible. And I think we'll have to just wait for longer-term data.
Laura.
Yeah.
Sorry, inpatient in liver transplant list, because of the early recurrence post-transplant, do you prefer to wait and treat them after liver transplant? To treat with liver transplant and treat the virus C after liver transplant?
For the hepatitis C virus infection?
Yes, of course.
So I would probably defer that to the people who do liver transplant day in, day out. It depends on, I think, what their liver disease stage is. It's a very fine balance with the MELD scores and their hepatitis C treatment. There are several decision analyses that I think are actually the economic models that people project, modeling studies. They're out there that would suggest that 20, MELD of 20 is the soft point. So it's more around MELD than anything else. That if it is less than 20, then you go ahead and treat. If it's more than 20, then you wait, because the risk is that you will lower their MELD, they won't get the transplant, and then the outcomes are going to be worse. So it's more complicated than just that one aspect.
In fact, we have a talk tomorrow about that issue.
Just linking very quickly with what Ray said, the VA is in a very unique opportunity because I think you have treated almost all your population of patients with hepatitis C, or a huge percentage of your population. So I think that if you start an observational study at this point, you will have unique information within the next year to 5 years as to the frequency of HCC post-DAA. So what do you think about that?
No, so we are going to continue. So this is an earlier study. Our average follow-up was 15 months. So it's really early. And the plan is to wait for maybe a year or two. I think doing anything sooner than that would just be an overkill, and try to understand this again. One other aspect that I think might be relevant, though it might be hard to study, is that there might be some regression in fibrosis over time. I do not know if and to what extent that might happen. So the risk might actually start, instead of seeing that the graphs are getting separated, they might actually start getting closer.
Yeah, I'm just wondering if you focus on those guys that are relatively advanced FIBS or any other form of fibrosis scores, and those that have cirrhosis,
Right.
and then just continue with that group of patients.
In those populations that are already cured, the VA, you still have other risk factors like obesity, NASH, cirrhosis. So you might still be seeing hepatocellular carcinoma, but not because of Hep C, but for the risk factors.
Absolutely, because we saw that actually patients who had alcohol was an independent risk factor for HCC.
Okay.